Okay, I think we're live now, and I'd like to welcome everyone to our fifth and final program of our 2020 PBC Speaker Series. As many of you know, throughout September, we've given out daily prizes as part of our PBC Awareness Month. And tonight, I'm very happy to announce that our grand prize winner of the 32 gigabyte iPad is Miriam Vanderross from Maple Ridge, British Columbia. Congratulations, Miriam, and all the winners this month who continue to spread PBC awareness. Tonight's guest speakers will be familiar to many of you who have attended past Canadian PBC Society events, whether on Facebook or in person, in Calgary, Toronto, Halifax, or St. John's. I'm pleased to welcome Dr. Mark Swain from the University of Calgary, who will discuss PBC fatigue, and Dr. Magnus McLeod from the Dalhousie University in Halifax, who will discuss PBC symptoms. And now I'm pleased to turn things over to Dr. McLeod.
All right. So that should be sharing now. Thanks for the introduction, Gail. I'm going to be talking about primary biliary cholangitis, PBC, and I'm going to specifically be talking about some associated conditions as well as pruritus or itching. So overall, I'll be talking about the autoimmune conditions associated with PBC. I'm going to be talking both about hepatic or liver-related autoimmune conditions and non-hepatic autoimmune conditions. And then I'll be talking at the end about pruritus. So the associated autoimmune conditions that are hepatically related or liver related include three main ones. There's primary biliary cholangitis, PBC, which everyone is aware of. And then there's a very similar condition called primary sclerosing cholangitis, or PSC. The other related autoimmune liver condition is autoimmune hepatitis, or AIH. And these are quite overlapping. And so many patients with PBC, not many, but the minority of patients with PBC also have accompanying autoimmune hepatitis. And some patients with primary sclerosing cholangitis also have overlapping autoimmune hepatitis. It's quite rare to have overlapping PBC and PSC, but still possible. Autoimmune hepatitis is a disease that shares many of the symptoms of many other liver diseases, and these symptoms can be quite non-specific, including fatigue, abdominal discomfort that's fairly non-specific, difficulty sleeping, itchy skin or pruritus, joint pains, nausea, and a loss of appetite. The diagnosis is a bit different compared to patients with PBC. It includes abnormal liver enzymes, but these abnormal liver enzymes include AST and ALT rather than the abnormal alkaline phosphatase associated with PBC. And they have positive antibodies, but they're different than the PBC antibodies, such as anti-mitochondrial antibody. And these are mostly anti-smooth muscle antibodies, but there are others. A liver biopsy is required to diagnose autoimmune hepatitis, but as many people are aware, a liver biopsy is not required to diagnose primary biliary cholangitis. The treatments are different as well. Autoimmune hepatitis is treated with steroids and other immunosuppressive medications. PBC and PSC are both cholestatic liver diseases, meaning that they both affect the biliary ducts of the liver, while autoimmune hepatitis that I mentioned before affects the liver cells or the hepatocytes. PSC is different from PBC in that it affects more men than women in a 60% to 40% ratio. PSC affects the bile ducts within the liver as well as outside the liver, while PBC affects the bile ducts inside the liver. Patients with PSC, or primary sclerosing cholangitis, also have inflammatory bowel disease in many patients, which is a type of diarrheal illness that's inflammatory in nature. PSC is diagnosed mainly based on imaging, usually an MRI of the liver. Unfortunately, there are no medical treatments for PSC, unlike for PBC, where we have ursodeoxycholic acid and other treatments such as obeticholic acid. PSC also has a higher risk of cancer, and so I have here listed in red. Patients with PSC are at higher risk of colon cancer, but also gallbladder cancer, bile duct cancer like cholangiocarcinoma, as well as liver cancer if they have fibrosis of the liver. The autoimmune conditions that can be seen in patients with PBC can also be unrelated to the liver. And there are over 100 autoimmune disorders. I just have some of them listed here, and they can affect every organ in the body. And I'm just going to talk about some of the ones that are more common in patients with PBC. The most common associated autoimmune condition is actually autoimmune thyroid disease. Other ones include Sjogren syndrome, Raynaud's disease, rheumatoid arthritis, celiac disease, and CREST syndrome. I'll talk about them more specifically in just a moment, but if you look your attention to the bar graph on the right, about 33% of patients with primary biliary cholangitis have an additional autoimmune condition, such as one of the 5 or the 6 that you see on the left. And about 20% of patients have 2 or more additional autoimmune conditions. And with autoimmune diseases in general, if you have an autoimmune disease, you're at higher risk of developing another one, and you can have many autoimmune diseases at once. I'm going to talk a bit about these different autoimmune diseases and just show you that there's many overlapping symptoms. And so it's very important that if you have symptoms associated with your disease, such as PBC, it's important to talk to your healthcare provider to ensure that you don't have an overlapping autoimmune condition in addition to your PBC. So starting with primary biliary cholangitis, fatigue is quite common, in addition to pruritus or itching, which I'll talk about at the end, but also dry eyes and dry mouth, difficulty or trouble concentrating, and skin discoloration. Primary sclerosing cholangitis is quite similar in regards to its symptoms, but diarrhea is included because there are many patients with overlapping inflammatory bowel disease, which is a type of autoimmune condition. Autoimmune hepatitis also is affected by fatigue, pruritus, but also these patients have joint pain and swelling as well as skin discoloration. Autoimmune thyroid disease. Over on the top left, I have the thyroid can be both hypothyroidism and hyperthyroidism, and the symptoms are quite extensive. And you can see if you have any thyroid condition, you can have fatigue, you can have pruritus or itching, joint pain or swelling, cold sensitivity, diarrhea, and even constipation, weight loss, weight gain, trouble concentrating, and skin discoloration can occur. It's very important to ask your doctor to ensure that you're being tested for autoimmune thyroid disease. And I test my patients with PBC every 6 months to ensure that their thyroid is not underactive or overactive. Sjogren syndrome is an autoimmune disease that affects the mucus-producing ducts within the eyes and the mouth, but it also can produce more systemic symptoms as well. The most common symptoms include fatigue, pruritus or itching, dry eyes and dry mouth, joint pain and swelling, as well as weight loss. Celiac disease is an autoimmune disease that affects the small bowel, and this can lead to symptoms such as fatigue, not only from the autoimmune disease itself, but it can also cause iron deficiency anemia, which can lead to fatigue, but it can also produce diarrhea, joint pain and swelling, as well as weight loss. Rheumatoid arthritis is an autoimmune condition that affects the small joints of the hands and feet, but it can cause, as seen above on the right-hand side, a very systemic disorder that can lead to a multitude of symptoms. The main symptoms that can be overlapping with other autoimmune diseases include fatigue, joint pain and swelling, as well as dry eyes and dry mouth. Raynaud's disease is a condition that's actually seen quite commonly in patients with PBC, but many other autoimmune conditions. This condition causes a cold sensitivity where you get skin discoloration, especially in the tips of your fingers, but also your feet and sometimes your face, that can lead to the pictures above. CREST syndrome, also not an uncommon disease, can lead to many overlapping symptoms. When it says CREST syndrome, this causes calcifications of the joints and other parts of the extremities. It can also lead to Raynaud's phenomenon, which is similar to the Raynaud's disease, which I mentioned before. It can lead to esophageal or the food pipe in your esophagus dysfunction, leading to heartburn and problems with swallowing. It can lead to sclerodactyly, which is a tightening and thickening of the skin of the fingers and hands. And I've shown that on the right as well. And then also telangiectasias, or abnormal dilation of blood vessels in the face. The nonspecific symptoms that can be quite devastating include cold sensitivity, diarrhea, skin hardening and thickening, heartburn, and skin discoloration. So as you can see, many of those overlapping autoimmune conditions can be difficult to differentiate based on symptoms. And so it's very important if in someone who has PBC, if you develop new or worsening symptoms, don't just blame your PBC, but talk to your healthcare provider. And then I have a short segment here on pruritus or itching. And the first thing I wanted to say was that you have to know that there's the rash that itches, but also the itch that rashes. The picture on the left is the classic picture of hives. And hives are a skin condition that causes itching. It's not related to your liver, but related to a dermatologic issue. The rashes on the right are both rashes that are caused by the itching itself. And so it's important to try to notice, is there a rash that's causing me to itch, or is the itch itself causing the rash? Over the course of the disease PBC, up to 70% of people can experience pruritus. And it's very important to know that pruritus isn't something that you have to deal with in silence. It's important to talk to your physician and see if treatment was warranted. There are treatments for this. The first thing, and it's important even if you're being treated for your itching, to avoid excessive washing and bathing. This can increase skin dryness and worsen the itching. Be careful with dermatologic or skin irritants. Very hot and spicy foods can sometimes make it worse. And then stress in general makes most symptoms worse. And it's good to apply topical lotions that contain tannins, camphor, or menthol. Skin moisturizers are good. Mild, non-alkaline soaps and lukewarm water. Wet, cold, or moist wraps. Relaxation techniques, and also training to stop the cycle of itch, scratch, and itch, which is mainly through relaxation techniques, but psychological counseling can help. Other considerations is that with PBC, patients are at risk of gallstones more so than the average person. And having gallstones can sometimes, in certain situations, increase the itching. And it's important to, if you have new or worsening itching, to ensure that you don't need liver or biliary imaging as part of the diagnosis. Obeticholic acid, or Ocaliva, is one of these new medications for PBC, and this can make itching worse. So it is important to know that the Ocaliva could be worsening your itch. And then there are other systemic diseases such as kidney disease, diabetes, such as diabetic neuropathy, hyperthyroidism or thyroid disease, like I mentioned before. And then there are some hematologic diseases that can worsen itching. The pearl is, it's good to inform your physician if you do have itching, or especially if your itching has gotten worse. The most common medications used to treat itching in PBC include cholestyramine, rifampin, naltrexone, and sertraline. And these are what are in the guidelines that physicians use to treat these itching. But there are other medications such as gabapentin, as well as bezafibrate, which is one of the newer treatments for PBC that isn't in widespread use yet. The way I like to treat itching is a little bit different than the guideline approach, but it is important that you consider, is it my sleep that's a problem? Because insomnia can worsen itching, and insomnia can make that vicious cycle of stress worse and itching worse. And so sometimes in cases where insomnia or pain is an issue, I start with gabapentin, and that can sometimes make the itching better. If that's not the issue, I do ask about issues with depression and anxiety, as sertraline is a very safe medication to use in patients with PBC and itching. And the only issue with sertraline is it can take anywhere from 3 to 6 weeks to have a good effect. If depression and anxiety aren't a big issue, I do see if there's an inadequate response to ursodeoxycholic acid and or obeticholic acid, because bezafibrate may be a good option in patients who aren't having a full biochemical response to their medication. Then after that, if those aren't an option, or if or they're not working, I'll then move on to cholestyramine, which is a very good medication for itch, and then sometimes move to rifampin. And then if naltrexone doesn't work, or any of the other previous ones, I will refer to dermatology, not only to investigate whether there's a skin reason that the itch is happening, but also that they can prescribe UV light therapy. So that's all the material I have. And if there's any questions, I can try to answer them.
Okay, thank you so much. That was an excellent presentation. It almost answered all of the questions I had, but I do have some that we've received from our previous programs, and we did not have the time to answer them. So this question came from Tiffany during our last broadcast, and she said, can there be a reduction of itch with age or menopause?
Over the time with PBC, sometimes patients' itch does get better for the duration of the disease, but with menopause, it's hard to say. Sometimes age itself also increases skin dryness, and sometimes the itching related to dry skin can be worse. I haven't noticed much in the way of like postmenopause versus premenopause in how it affects the itch. So I wouldn't say that it makes it better or worse, but sometimes over the course of the disease, it does improve in regards to the itch.
Okay, thank you. Marilla asks, are my severe dry eyes PBC related?
They definitely could be. It is important to talk to your physician to see if you have other autoimmune conditions such as Sjogren syndrome, which I mentioned in my presentation, but dry eyes are a very frequent problem in patients with PBC.
Okay, Sandra asks, can itching come and go?
Yes. With PBC, the itching is quite intermittent, and it's hard to have it's hard to say when it'll come and when it'll go, and it doesn't have to be all the time, but it does come and go.
Okay, Tina asks, I lost Tina's question here. Oh, can OCA cause muscle and joint pain?
It's not a common problem, but I have had some patients who have been taking obeticholic acid complain of some muscle and joint pains, but it's not very common. Okay,
and men are thought to have more aggressive disease, like with PBC. Does that mean they have worse symptoms?
Not that I'm aware of. I haven't noticed that men have worse symptoms, and I haven't seen that in the literature that I'm aware of. It may be that because they have less symptoms, the disease is picked up later, but I haven't heard of them having worse symptoms at all.
Okay, and Bree asks, is there a connection with tooth loss and PBC?
Tooth loss?
Tooth loss, I guess dental issues.
Not that I know of.
What was actually with Zika, you can get dry mouth, and then you can get dental caries from that, but not tooth loss, except for the tooth decay and gum disease that comes with dry mouth.
I thought you said tooth floss.
Oh, I was trying to really enunciate tooth loss. Yes. Okay. And
that's great.
If someone has a celiac or Sjogren's or some of these other diseases that people have, does it worsen their PBC?
No, not that I'm aware of, but it can worsen the symptoms of PBC and make them a bit more difficult to treat.
Okay. Carol says she's from New Brunswick and she has decided to put apple cider vinegar in her bath. Any comments on that?
Apple cider vinegar is quite a common remedy that I've seen my patients use. I don't think it has any benefit in regards to ingesting it, but if you put it in your bath and it makes your symptoms better, I have no problem with that.
Okay, those are the questions that I have right now from our Facebook Live panel and the ones we had from previously. So I think what we'll do is we'll turn it over to Mark. If questions continue to come in on the Facebook stream, will you stick around, Magnus, to answer those?
Yeah, I'll be around until 8:30, but I may have to sign off at that time.
Oh, well, we're going to end at 8.
Oh, sorry. 8:30 Atlantic time.
Okay, then, for those of you who have questions for Dr. McLeod, we'll have to perhaps email them to him and get back to you. So if you are going to say goodbye to us, I'd like to thank you so much for all you do to support your PBC patients and spread PBC awareness, education, and treat people. That's really the name of the game. So thank you, Dr. McLeod.
I'm sure if there are other questions that come in, I have confidence in Dr. Swain's responses.
That too. Okay, and with that, I will turn it over to Dr. Swain, who will be talking about PBC fatigue, something that he's been working on for many years and has become a world expert actually in this field.
Thanks, Gail, and thanks, Magnus. That was a great presentation. So I'm just going to talk about one symptom, and although throughout Magnus's presentation, I'm sure you all saw that pretty well every disease he showed, fatigue, it was an issue, and so fatigue is an issue in many chronic diseases, but certainly in PBC, it can be quite significant. And I'm going to talk to you, I think, broadly and more theoretically for most of it, and maybe some future approaches to fatigue at the end. When most people think about wellness, everyone has their own idea of what wellness is, but I usually divide it into two different things. I divide it into subjective wellness, which is how I put it as I feel well, or objective wellness, which is my test results are normal, so I am well. And many physicians focus more on this side of the equation, and sometimes a little less on this side of it, because subjective things are a little bit harder to get a handle on, and often because it's based on an impression, and you have to do questionnaires or ask patients directly. In busy practices, often they're not really sought after. And so when you look at fatigue and PBC, these are some of the characteristics that you see. First of all, it's the most common symptom that people experience, just like in all the other autoimmune diseases that Magnus was talking about. And it can be quite profound in some patients. In fact, they really have different challenge functioning. Typically, the fatigue scores are higher in women than men. I think that Magnus touched on that. And they're not correlated with disease severity. So someone who has mild disease or minimally elevated serum alkaline phosphatase might have profound fatigue, whereas someone that has more advanced disease or higher serum alkaline phosphatase might feel totally fine and have no symptoms. The fatigue scores seem to increase with longer disease duration based on this study from the UK. Itching is more common in people who are younger. I think this goes along with the fact that people who are younger typically have more aggressive disease. And although I put here it's not improved with transplantation, in fact, it probably improves a little bit, but it doesn't go back to baseline and what would be considered normal. So the question is, does improvement in my liver tests, which is the objective measure that physicians often follow and will say, well, your liver tests are normal. Does that mean that my fatigue, which is a subjective measure of my disease, will also get better? And so there's quite a bit of data with regards to UDCA therapy and symptoms. I've just put up one of the studies, a bit more recent. However, these observations go quite far back, and these are basically the symptoms along the bottom. And you can see people that respond to UDCA, which is in the blue column here, or they are non-responders in the red. It doesn't matter with regards to fatigue. The fatigue is the same. So the response to UDCA does not improve fatigue in these patients, and this was described right back to the original publications. What about obeticholic acid, or OCA? Well, this is the study that basically got this drug approved in the New England Journal of Medicine. Here's fatigue here, and you can see the fatigue does not get better with OCA. In fact, maybe even at the higher doses, it might make fatigue a little bit worse, probably more related to its impact on pruritus or itch, as Magnus touched on. And so when you're talking about fatigue, I like to break it down into two main sort of types of fatigue. When I'm talking about central fatigue, I'm really talking about changes in neurotransmission within the brain. So changes in brain function that drive fatigue, compared to peripheral fatigue, which is the type of fatigue that we would experience if we were working out, or which is really driven by neuromuscular changes. And broadly, the fatigue in PBC is really central in origin, so it comes from the brain. And so really what happens is you get this disease that's happening in the liver. It's an autoimmune attack on the small bile ducts. And this drives changes in brain function, which is really alterations in what's called neurotransmission, just how the neurons talk to each other in the brain. And then this gives rise to behavioral manifestations, which everyone a patient would call symptoms, which Magnus touched on. But these symptoms in PBC really fall into these main categories, and fatigue is the most common symptom. It doesn't have to be associated with a decrease in motor activity, but it often is. It can be associated with loss of motivation, social withdrawal. People stop really getting out and seeing friends and participating in social activity, disrupted sleep, mood changes. Really, depression is the most common, and anxiety, and cognitive impairment, which most patients would describe, I think, as brain fog, or they forgetfulness, things like that. And Magnus touched on that as well. And so the question is that we've been interested in for quite some time is what is the signaling mechanisms that goes between a liver and the brain? Because they're not connected. People don't think of them as being connected. Obviously, your brain's in your head and the liver's down in your abdomen. And what is the signals that bring about these changes in the brain? And our group has been working on this for quite some time. And really, when we look at it, we really break it down into three main things that happen. First of all, there are things when you get liver inflammation, which happens during an autoimmune liver disease like PBC, and you get release of things that are important for driving inflammation into the circulation. Cytokines are some of this, and really these are the main cytokines. Really, tumor necrosis factor alpha, or TNF alpha, and IL-6 are the two most important ones. Probably TNF alpha, probably the most important. And these can activate nerves, which carry signals up into the brain, and they cause changes in the brain that bring about fatigue. These cytokines can float in the blood up into the brain and then go into the brain, or in areas of the brain that don't have a blood-brain barrier, because normally our brain is sealed off from the rest of our body and stuff can't get into it easily, except for some parts of the brain where they could get in. And then the pathway that we've actually described in our lab is that these cytokines activate immune cells, and those immune cells then go up to the brain, and they actually go into the brain, and they change how the brain functions, which leads to fatigue. We're also very interested in how PBC changes the brain. So these signaling pathways are abnormal, and they drive these changes in the brain. However, often when people go to a doctor, they'll say, well, you know, and they say they're fatigued because it's a subjective thing. I think often these symptoms are minimized or ignored, or they can be. And so we were very interested in trying to identify changes that were what we call objective. So they're just like a blood test. You could say, aha, this is different in people with PBC, and this could explain their symptoms. So we use functional MRI to do that. Using functional MRI, we've actually found that there are structural and functional changes, which we call objective changes, in the brain that are characteristic of people with PBC. And these changes occur in parts of the brain that are well known to regulate behavior. And the functional changes are alterations in how the nerves talk to each other. We call that neural connectivity. Or they're structural changes, and this is damage to or inflammation of or change in size of different brain regions. I'm just going to show you a few of the things that we've shown that really define that the brain in PBC patients is not normal. It's different from the brain in people that do not have PBC. There are objective changes. So first, what about neural connectivity? Well, this is a study that we did, and essentially, it doesn't really matter what all this shows, but what I'll just say is that if you look at these blue blobs here, this is a group of PBC patients compared to a group of healthy controls. And what these blue blobs show, these are PBC patients with fatigue or without fatigue, that the blue blobs show that people that don't have fatigue, that they do have fatigue, their connectivity with their thalamus, which is a very important part of the brain that kind of regulates how the brain talks, is less. So what these colors show are changes in connectivity within the brain, so how the neurons talk, that is characteristic of people with PBC and is associated with fatigue. What about alterations in brain structure? Well, I'm going to talk about just a couple parts of the brain. This part of the brain called the hippocampus. It's very important in humans for regulating mood and mainly depression, cognition. So it's a key regulator of the symptom like brain fog, and memory and movement. And in people with major depressive disorder, so this is people that with quite significant depression, their hippocampus gets smaller. And this is one of the classic findings in people with major depression. And people with major depression often have brain fog, and obviously fatigue is often very common in those individuals as well. So when we looked in patients with PBC, and this is 17 patients with PBC compared to 17 patients that were healthy controls, and these are PBC patients that don't have cirrhosis, that the hippocampus was smaller, about 5% smaller in the PBC patients. And so some people say, well, 5%, I mean, what does that mean? It's tiny. Well, actually, this change in the size of the hippocampus in the PBC patients is almost identical to the change in size of the hippocampus in people with major depressive disorder. And in fact, in people with major depressive disorder, there's some evidence that exercise and antidepressants can actually make the hippocampus get bigger as their depression gets better. And so it's something that might be, considered or adapted to treating people with PBC. Now, when people use the word neuroinflammation, that's just a fancy word for meaning inflammation of the brain. We all know if we get an inflammation in our joint, that's when we get a swollen joint, and we might take Advil or something for that. That's inflammation in the joint, but the brain can become inflamed as well. And in fact, you can look at it using MRI with something called QSM, which stands for quantitative susceptibility mapping. It doesn't matter, just call it QSM. And what it means is that iron is being deposited in the brain. And this indicates neuroinflammation. In fact, it's used in the disease multiple sclerosis and in Alzheimer's disease to show inflammation. And you can see this where it goes whiter here than compared here, that's iron being deposited in a patient with multiple sclerosis. And these diseases are commonly associated with brain fog and altered thinking or memory, and also depression and fatigue. And so when you look in patients with PBC, what you see in their hippocampus again, that their QSM is increased significantly, suggesting that they have neuroinflammation or inflammation in their hippocampus. And the question is this driving the changes in hippocampus size? So when I'm thinking about symptoms in patients with PBC, I think it's important to focus on the blood work. Obviously, that's important, and that's a target of therapy. I think it's also important to recognize that these symptoms are extremely important, and for someone to actually say, I am well, that both of these things have to be improved or better, certainly addressed. So just want to finish off by saying that I think in the future, when you recognize that there's these objective changes in the brain and also changes in these pathways signal between the liver and the brain to bring about changes in the brain, well, these could be targets, and they could be targets for treatments with medications or behavioral therapies like cognitive behavioral therapy, exercise therapies, which are used in depression and increase the size of the hippocampus, or even modified antidepressant regimens. And that patients with PBC have these objective changes in the brain that are linked to their symptoms. And so it's not that when the patient might get told, well, it's all in your head. Well, it is all in your head because there are changes that are happening within the brain that are driving these. And I think that we can address the changes in the brain, or we can address the signaling pathways, and hopefully over time we'll have therapies that will directly treat these symptoms, which can persist despite the fact that the liver test normalizes, as I mentioned before. And that's all I have to say. I'm happy to take your question.
Thank you so much. That was really interesting. I have a question, and then I've got lots of questions from our Facebook audience. My question to you is, in 2006, you wrote a paper published in the Canadian Journal of Gastroenterology. Do you remember that one?
I do.
On fatigue in the liver, and you concluded that fatigue and liver disease appears to involve changes in central neurotransmission, which results from signaling between the diseased liver and the brain.
Yep.
And I can post a link to that article if you think that would help people to understand it more. It's a great article. And that was like 14 years ago. Yep. What has your journey been to get to understand this hypothesis or theory or conclusion? And how did you let that evolve or roll out? What was your plan back in the day?
You're assuming I had a plan. No, I didn't. So a lot of that was based on I think on more theoretical things. Actually, we hadn't really started or embarked down doing studies in patients. A lot of it was actually based on animal research and research in other different areas. And so when I wrote that article, it was really based on findings we'd made in animal models of liver disease, actually. And so after that, we became very interested in how do we address this in patients. So we actually developed a team in Calgary. We called ourselves the Brain Team, and we had neuroscientists, psychiatrists, neuroimagers, and we actually were funded through the Canadian Institutes of Health Research, or CIHR, for a 5-year grant to really look at this. And this is where all of this data came from about patients. And when we first started, we weren't sure what we'd find because, of course, it's unclear. There's not a lot of information about chronic diseases and changes in MRI scans. Most of it's in diseases that affect the brain that are known to affect the brain, like multiple sclerosis or Alzheimer's disease. And so when we looked in PBC patients, we were actually very surprised to find changes that were the same so when we looked at a whole group of patients, we found very, very similar changes in the brain in the PBC group versus non-PBC, making us realize that the changes we were seeing were really PBC specific. And we've actually gone and looked in people with inflammatory bowel disease, and they have, even though it's an immune-mediated disease in the gut, those people have very different changes in the brain than people with PBC.
Okay, Mark, can you put down your screen so that we can get a better picture of you?
Yeah. How's that? Is that better?
Not yet.
Okay. Oh, hang on. I got to stop sharing here. There we go. How's that?
That is really good.
Okay.
Okay. So we have like a ton of questions come in. I hope I can represent what the people are asking. So Susie asks, fighting fatigue, advising patients to exercise, but they're too tired to exercise. How can they build up strength and endurance when they're tired?
Yeah, I mean, that is always the biggest issue. But interestingly, if you look at all of the fatigue-associated diseases, and I think if you go back, and I guess chronic fatigue syndrome would be one of the sort of hallmark ones, if you actually do what's called a graded exercise program. So the problem that a lot of people have is that they go, I'm going to exercise today, and they go out and they do half an hour on a treadmill, and they can't get out of bed for the next 3 days. And so that is completely counterproductive, and that's not graded exercise. That's wishful thinking exercise. And I think we all do that because we think that, you know, we can just get out there and do that. But I think it's really important to start off with what you can do, and then slowly increase it. And that's what graded exercise means. And so it's very important, if walking around the block exhausts you, then walk around half the block. Yeah, and then after a week or two of that, then try to do the whole block or 3/4, and then just try to increase it with those type of sort of simple steps until you get to a point where you feel like you're getting an aerobic workout, and then that's your exercise. And so I think it's very important to take a graded approach and don't overdo it and get disheartened.
Okay, thank you. Karen asks, can brain structure changes be related to migraines?
That's interesting. I'm not a migraine person. I don't know if you mean migraines broadly or migraines in PBC. I can't tell you that. I can tell you that none of our patients that we included in our study had migraines. So we actually had certain things that we wanted to exclude, and we excluded people that were on antidepressants or had history of significant depression, and anyone that had significant history of migraines or things like that we excluded. So I don't know, but very interesting. I think unlikely, because usually there's not a structural defect in migraines, but it's more of a vascular issue. But the interesting thing is, I didn't present that data, but very recently we did some work where we looked at oxygenation of the brain in people with PBC, and we published this a couple of years ago now, where we just took the same sort of thing that they would put on your finger when you went to a doctor to measure how much oxygen's in your blood. It shines that red light through your finger, and basically that looks at oxygen in your blood. And we put a derivative of that on people with PBC's forehead. And what we found was that there was a profound reduction in the amount of oxygen that was getting to what's called their frontal cortex, which is in your front of your head, and to similar levels that people with multiple sclerosis had. And so we were completely and profoundly struck by this, but there's obviously changes going on which are probably vascular in nature. And so there might be some overlay between migraine, which is vascular, and these changes that we see with oxygen delivery.
Christian asks, do you recommend stimulants to improve fatigue?
I don't use a lot of stimulants. I mean, there was a study that looked at modafinil, and then there was a couple subsequent ones, and I think the first study suggested it was useful. This is a stimulant that's used for people with narcolepsy, but the other two studies showed not. Obviously, it depends on how profound you are, and it's an individual discussion with your physician. As I said, I don't use them much, but I think that they can be used, and they are widely used by some physicians. And so, I think as long as it's done in a responsible manner with your physician, then I think it's worth trying, especially if you're finding that you can't work, or that's profoundly impacting your quality of life. Then I'm a firm believer in doing what you have to do to improve your quality of life.
Okay. Are there any medications that might worsen fatigue that people take normally?
Well, normally, I mean, there are a number of medications people can be put on that worsen fatigue, and I think beta blockers would be a classic one. And so, beta blockers often make tiredness is a very common symptom. And I think that if you look at any drug that's released on the market, and you look at it compared to people that are taking a placebo, first of all, just taking a placebo can cause fatigue in people, and also often you'll see that there is a signal of fatigue in many of the medications that we take that would be prescribed for many different things that are very common. And so, I mean, obviously, if you start a medication and you're starting to become quite significantly more fatigued, then I think that's something I would discuss with my doctor about trying something else.
Okay, I've got quite a few questions here that are about symptoms in general.
Yeah.
Marianne,
I see Magnus has made a run for it, has he?
it's all on you there, Mark. Marianne asks, is it possible to have PBC with no symptoms?
Totally. Well, I would say, especially nowadays, there's a lot of people that are picked up on routine blood work, and they're found to have abnormal alkaline phosphatase, and then that leads to the diagnosis of PBC. And often they're completely asymptomatic, and so for sure, no symptoms is common. As I say, it doesn't relate to really the severity of your liver disease. So people can have significant liver disease and have no symptoms, and which is of course wonderful for them.
Okay, Lee has a couple questions. Her first one is, can fatigue come and go? And her second question is, can CBD help fatigue?
Yeah. So fatigue definitely can come and go. And I think people, often people do describe the up and down and sometimes with life precipitants. I think stress, and especially in the modern world we live in, of course, with COVID and everything else is going on around us right now. I mean, stress in the world is really high, and so stress leads to fatigue in people that don't have PBC. So if you have PBC and you have fatigue, then certainly I could see as stress in one's life cycles that one could see a fluctuation in their fatigue. The question about CBD oil is fascinating. I'm very interested in cannabinoids and CBD oil, CBD. And I think in Canada we're in a unique position that people are totally open and free to try it. And as I always say, I have patients ask me all the time, should I give it a whirl? And I say, if they're having significant fatigue, I say give it a whirl. And if you feel better, fantastic. But do a time, don't just go on it if you're not feeling better to stay on it. But I would, give yourself a trial of it and see. And if you're feeling better, then I would just stay on it.
Jill asks, do hormones affect PBC or symptoms?
That's a very good question. Likely. Well, first of all, PBC has not been described in women before they have their first period. So obviously there is some hormonal impact. Also, people who, especially with pruritus, people often fluctuate around their periods, women, and so often they'll find the itching gets worse just before they have their period, and so they actually know their period's coming because they get itchy. So there is definitely a hormonal impact on that symptom. The fatigue is hard to know because, of course, when people, especially if you're still having periods, I mean, there's all the issues and symptoms that go along with having a period, which is going to make fatigue often worse anyways. So I don't think there's much literature on that with regards to some of the other symptoms. And I don't think from dry eyes, dry mouth, that sort of thing. I'm not aware of any kind of pattern that goes along with cycling hormones.
Okay, thank you. Sean is asking, do joint pain and muscle weakness come, or why do they come with PBC or liver disease in general?
Yeah. I mean, that's a good question. I would say that, joint pains are common, right? And as we get older, they get more common. And so a direct association between joint pains that is not rheumatoid arthritis and PBC probably is not a strong link. However, with rheumatoid arthritis is an autoimmune disease that is linked to PBC. So you can have rheumatoid arthritis and PBC together. And of course, they are directly linked. I can't remember the rest of it. Was there another part of that question? I forgot.
About joint pain and muscle weakness.
So muscle weakness, it's interesting because certainly in the patients I treat, I don't see a lot of muscle weakness, but I know that in England, David Jones, who is very interested in fatigue and PBC as well, and he has shown some changes in the muscle function in people with PBC and fatigue. The problem is there's always this mixture of if you're profoundly fatigued, and then you're not maintaining your physical conditioning, then you become what's called deconditioned. And so you get muscle changes in people that are deconditioned. So it becomes a blurry line to figure out which is coming. Is it the PBC driving it, or is the deconditioning that's driving that weakness?
Okay, Chris asks, is there any drug interactions between antidepressants and URSO?
No,
Yes.
I'm not aware of any interaction. And in fact, if someone is depressed, then which is much more common in chronic diseases, especially immune-mediated diseases like PBC, then I think it's absolutely important that first of all, there's a discussion with your healthcare provider. But I think if the feeling is significant enough, then definitely antidepressants should be considered. And I mean, sertraline is an antidepressant used for itch, right? But also can work for depression.
Do you know of any studies that are looking at fatigue and mindfulness?
Yeah, well, so I know there's a lot of people interested. Pranita Tandon in Edmonton is very interested in that, and she actually did a really cool workshop on that in one of the PBC sessions. I can't remember what city it was in now, maybe Ottawa or somewhere. But and it was, you know, I think that traditional medicine it looks at the objective outcomes of disease. So it looks at your liver tests, it looks at the things like your FibroScan, the numbers that we can look at. And that's what traditionally doctors look at. I think that the other part about I'm feeling well, I think is less looked at. And I think when you look at Eastern medicine, and so, you know, whether it's yoga or acupuncture or other type of techniques, I think that's underexplored. And I actually think that it's an area that should be explored more. I think there's a lot of benefit that people can get out of those kinds of things.
And what are your thoughts on herbal remedies that propose to give you energy? Any you recommend, don't recommend?
So I don't believe there are really any herbal preparations that give you energy. You know, I think there's a lot of herbal preparations that describe that they will give you energy. And I also know that when you're looking at any clinical study that's looking at fatigue as an endpoint, if you don't give a placebo, then it's very hard to even interpret the data. Because if I take a sugar pill and I give it to one of my patients and say, this is going to make your fatigue better, I know that in a certain group of those patients, it will definitely make their fatigue better. It'll last between 3 and 6 months, which is the classic sort of placebo time frame, and then it'll fade over time. So what I say to my patients is, if you want to take herbal supplements, I'm totally okay with that, as long as it's not harmful for your liver, and most of them are not. And if you feel better on them, then I would recommend continuing to take them. But I wouldn't pick one out that's being marketed to improve your fatigue, because herbal supplements are marketed different than medications. They can have broad claims that are not actually, they don't have to prove them. They just have to prove that they're safe. So what a medication has to go through Health Canada to be used to say treat fatigue would be very different than an herbal preparation that says this will improve your fatigue.
Okay, we just have a couple more questions and then we have to wrap up because our time is coming to an end. I don't know if I asked you this because I'm trying to cross them out as I asked you, but did I ask you a question from Christina? Is epilepsy have any connection to PBC?
Yeah, no, you asked me about migraine, but I think not. I mean, there's no evidence of increased prevalence of epilepsy amongst people with PBC.
Okay, and I guess my last question is from me. What are your next steps with your research in this area? Because you've uncovered some fascinating conclusions, and I can't wait to hear what's coming next.
Yeah, so I mean, obviously, anything that we can do to change these objective alterations in the brain, we're very interested in doing. So we're actually looking at, we're putting a grant together right now to try to try different techniques that might improve fatigue as an outcome or symptoms. And so one of the techniques that we're quite interested in is transcranial magnetic stimulation, and you know, that's been used in depression for a long time, and we're very interested whether or not that can improve the symptom profile. And so I think that's quite interesting. There are a number of exercise therapies that we're very interested in trying to see if we can also change the hippocampal shrinkage, which is in depression. Certainly graded exercise programs can seem to do that. So we're very interested in that. And then we're also interested in different type of antidepressants and their effect. We've actually published a paper, I guess about two years ago now, where an antidepressant called mirtazapine, actually, we found that when we looked at a very large database in England, it actually improves survival in people with PBC. So we're quite interested in understanding how that does that. And so we're doing a lot of studies that are both, mainly right now we're more in the bench. We haven't moved those to patients, but obviously patients take mirtazapine. So we're very interested in exploring databases to try to get more insight into how that might be working.
Hey, that is very exciting. And we will post some links to some of your research papers, probably not in this transmission, but in a separate Facebook post. So patients can read further, and that's terrific. And I'd like to thank our tonight's speakers for everything they do to support PBC patients, including compassion in the clinic and dedication to research and teaching the next generation of PBC specialists. All of these things give us hope for the future and confidence in the present. So this speaker series has been recorded and will be posted on our YouTube channel for people to view in the future. And we hope to see everybody again. We're going to try to arrange another speaker series for February, which is Rare Disease Awareness Month. And hopefully we'll get some of our current speakers to give us updates on everything they've been doing. And so good night to everybody, and congratulations to all our prize winners and our grand prize winner. And thank you, Dr. Swain, for being here tonight with us.
My pleasure. Thank you, everyone. Thanks, Gail.